Welcome guys to this class on drugs and anesthesia part 2. Welcome everyone to the Unacademy YouTube channel. I hope all of you can see me and hear me well. Please do leave a thumbs up in the chat box if you're able to see me and hear me. This is for the runners up and it goes up to 1,000 rupee vouchers for the first 100 people. So make sure that you download the app and register for combat and give it a shot. Now, let's begin with our class for today. Yesterday we discussed the drugs in anesthesia part 1. So in that class I had specifically taught you guys about how is anesthesia carried out, how is general anesthesia carried out. First we start off with pre-medication, then we start off with induction agents. So here we started discussing the IV induction agents in detail. After that we will be discussing the inhalational agents which are used for both induction and maintenance of anesthesia. And if you guys come onto the app, we will also discuss the muscle relaxants and local anesthetic agents. Now, anesthesia pharmacology is a very important topic. For every exam, they will ask at least 1 to 2 questions from anesthesia pharmacology, which is a short answer for all of you. You can get those marks for sure if you just attend these lectures which I am conducting for you guys. Okay, so let's begin with ketamine. Now, yesterday we discussed propofol and thiopentone. The third important drug that we need to discuss is ketamine. Now, ketamine, as we discussed yesterday, is different from propofol and thiopentone. And how is that? So, ketamine has the opposite action on all other systems of the body. Okay, so in the cardiovascular system, it will increase the heart rate, increase the respiratory rate, and increase the blood pressure. Now, why is this important to us? Clinically, we require this in patients of shock or patients of hypotension or patients of trauma who are coming after a lot of blood loss. So in these patients, the blood pressure is already on the lower side. You do not want to lower the blood pressure further and cause ischemia in them. So here we will prefer ketamine as the induction agent in these patients. Okay. Then the next important thing about ketamine, which was different from the other IV induction agents, was that it increases the intraocular pressure and the intracranial tension. Okay. So why is it important to remember this? Whenever we have a case of raised ICP, okay, maybe your patient has head trauma, or he has tumor or hydrocephalus, obstructive hydrocephalus, or he has some kind of extradural or subdural hemorrhage which is expanding. In that case, in neurosurgeries, you will avoid ketamine as an induction agent. So this is asked in your exam very often. In neurosurgery, which of these IV induction agent will you not prefer? So the answer to that will be ketamine. Then the second thing is they will ask in eye injuries what kind of, or in glaucoma, what kind of IV induction agents will you not prefer? Again, that will be ketamine. Okay, in ketamine, as it increases the intraocular pressure and the intracranial pressure, you will avoid ketamine. After that, the next question that they ask is what is the induction dose of ketamine? So the induction dose of ketamine is 0.5 to 2 mg per kg. Usually they will not ask you the doses. It's not very important. For ketamine, the next question that is important for us is where does ketamine act? Okay. Now this is different. All the other IV induction agents act on the GABA receptors. However, ketamine has a different receptor. Ketamine acts on the NMDA receptor. So please remember this. Ketamine has different kind of action because the receptor that it acts on is different as compared to the other IV induction agents. Okay. Now the next thing is the question they will give you is in what kind of patients do we prefer ketamine? So I told you already, shock, hypotension and trauma patients, because here they will maintain the blood pressure using ketamine. The second is if you have a patient with asthma. Okay, so ketamine is the only IV induction agent that causes maximum bronchodilation. If your patient has asthma and he is having irritation of the airway, in that case he can easily have a bronchospasm. So you want to avoid using an agent which will prolong or which will increase the bronchospasm. In fact, you will give the agent which will do the opposite, something which will cause bronchodilation. So here the answer would be ketamine. Okay, so ketamine is preferred in status asthmaticus as it causes bronchodilation. Now, a few features about ketamine which are seen in especially in children. One is called as emergence delirium and the other one is called as dissociative anesthesia. What is emergence delirium? Whenever we induce a patient with ketamine, you will see that after they wake up from the anesthesia, that is when they gain consciousness, they will usually act a little delirious. They will start singing songs, they will start talking in a language in which no one understands, they will mumble things, they will be in a dreamlike state. Okay, so that is called as emergence delirium. So when the patient is emerging out of the anesthesia, the patient has a delirious behavior. Usually you can avoid this emergence delirium by giving benzodiazepine like midazolam along with ketamine at the beginning of induction of anesthesia. Now, the second thing which is characteristic of ketamine is dissociative anesthesia. What is dissociative anesthesia? I'll give you a very plain example. It is nothing but an out of body experience. So the patient, his eyes will be open, however he will not be taking into account his environment at all. So he will have an experience like he is standing at the corner of the room and watching himself when he is under anesthesia. Okay, so you will see that the patient is glassy eyed or he has an nystagmus in his eyes and he is awake, eyes are open, however he is not actually synchronized with this environment. Okay, so that is called as dissociative anesthesia or out of body experience which is seen with ketamine. And last but not the least, we have discussed this yesterday also, ketamine is preferred whenever you have a full stomach patient. Okay, anyone who's coming with a full stomach, you will prefer to give them ketamine because ketamine helps in maintaining the airway reflexes. So if there is any aspiration of food material, in that case you will be protected from aspiration pneumonitis. Okay, Naveen Kumar is saying, how can a patient play a keyboard while undergoing brain surgery? What type of anesthesia is given, ma'am? Okay, so yes, I do know that there is something called as awake craniotomy. Okay, so in awake craniotomy, what they do is that the patient is made to either play a keyboard, sing a song, or do a particular or recite something in order to cut through that part of the brain. So in awake craniotomy, what they do is when they are going to open the brain, okay, so the painful part, that is opening the skin, subcutaneous tissue and the skull and the dura, these are the four painful parts. At that time we give propofol to the patient to make him unconscious and to make sure that the pain is gone. Now once the dura is open, the brain usually does not have any painful structures. So when the operation on the brain is being carried out, at that time the propofol infusion is stopped, the patient is woken up, he is asked to play the keyboard. Now why are we doing this? Suppose the patient is playing a piano sequence and if he makes a mistake in that, or if he starts desynchronizing in that, you know that you are stimulating the area of the brain that will affect his musical ability. So you will not cut through that area of the tumor. Okay, so that is something which is a part of awake craniotomy. Again, when you are going to close all the painful structures like the skin, subcutaneous tissue and the dura mater towards the end of the surgery, you will again give the patient propofol infusion so that he does not feel the pain. So only when we are operating on the brain which is not painful for the patient, you make him awake and you ask him to play the keyboard. Okay, now the next drug that we are discussing is Etomidate. Okay, now Etomidate, what is the most common question asked about it is, where is this drug preferred? So Etomidate is preferred in cardiac surgery. Okay, so Etomidate is preferred in cardiac surgery because it is the most cardiostable induction agent. What do you mean by cardiostable? So it is not going to cause any change, or it will cause minimal change in the heart rate and blood pressure of the patient. Now, if you have a patient who has a cardiac condition like a recent myocardial infarction, in this patient you cannot allow much hypotension or hypertension or much change in the myocardial oxygen demand, or he can have a re-ischemia. Okay, so we want to use an agent over here which will constantly maintain the blood flow of the heart. So here the agent of choice will be Etomidate. If they ask you in your exam in cardiac surgeries which is the agent of choice, just blindly go ahead and mark it as Etomidate. Okay, now next is, what is the dose of Etomidate? 0.2 to 0.6 mg per kg. Another the first most important question that comes about Etomidate is what kind of surgeries it is used for. So we have discussed this, cardiac surgeries. The second thing that they most commonly asked is what is the most common side effect of Etomidate. So the most common side effect of Etomidate is that it suppresses steroid production. Okay, so it acts on your adrenal gland and it reduces the action of 11 beta hydroxylase enzyme, and that will further reduce the production of corticosteroids in the adrenal gland. Okay, so you cannot give this to patients who are critically ill because they already have low steroid levels, and Etomidate will further reduce the steroid levels in them. So as a result of this, Etomidate should not be given in patients who are critically ill as they cause steroid suppression. Okay, now there is a question in which they always ask which of these drugs causes the most painful IV injection. So here the first answer that you should be giving is propofol. So if they ever ask you painful IV injection, the first one is propofol, most painful IV injection. The second one is Etomidate. Okay, next painful IV injection. So this is the order in which we'll be asking. Alright, now this is a question for you guys. Which IV induction agent is used for electroconvulsive therapy? Anyone, do you know the answer to this? Which IV induction agent is used for electroconvulsive therapy? It is shock therapy which is given in patients with refractory depression. Okay, the answer to this is methohexital. Okay, methohexital is the IV induction agent which is preferred for electroconvulsive therapy. Now let's move on to the next class of drugs in anesthesia, which are the inhalational agents. Now inhalational agents, they can be used either for induction of anesthesia, that is for putting the patient off to sleep, for making him unconscious, for beginning anesthesia. Okay, induction is nothing but beginning of anesthesia, beginning of unconsciousness, or it can be used for maintenance of anesthesia. Okay, now what is maintenance of anesthesia? Once the patient is already put off to sleep, you have to maintain that anesthetic state. You have to maintain the state of unconsciousness throughout the surgery for that patient. Okay, so suppose it is a 1 or 2 hour surgery. In that case, first you induce anesthesia using preferably an IV induction agent like propofol, thiopentone, etc. And after that you maintain the anesthesia by giving all these gases, inhalational agents, through the endotracheal tube that you've put in the patient. Okay, now what are these inhalational agents that we are talking about? We have the older inhalational agents like methoxyflurane, ether and halothane. Then we have the newer agents like desflurane, isoflurane, sevoflurane. Okay, so we will mostly be focusing on the newer agents. They hardly ask any questions on the older agents. Whatever are the questions that they ask, I will show it to you guys over here. Okay, so Ricky is asking, can Etomidate be used for elective intubation apart from cardiac surgery? Yes, of course, Etomidate can be used in any kind of surgery. However, it does not induce the patient very quickly. So if you have to prefer an agent between propofol and Etomidate, you will prefer propofol. But if the patient has a cardiac indication, if he has recently had a myocardial infarction or a cardiac arrest, or if he is undergoing a cardiac surgery, if he is undergoing angioplasty, or if he is undergoing coronary artery bypass graft, in those patients you would prefer to induce them with Etomidate. Okay, now Next is, what is the effect of inhalational agents on all the systems of the body? Okay. Alright. So in the cardiovascular system, majorly there will be vasodilation. Okay. So there will be vasodilation whenever you expose them to these inhalational agents, and this vasodilation will cause reflex tachycardia. Okay. Now, however, we have an agent which hardly causes any change in the heart rate or the blood pressure, and this is called as the most cardiostable inhalational agent. Now, it is very important for you guys to please read the question properly. Are they asking you most cardiostable inhalational agent, or are they asking you most cardiostable IV induction agent? Okay, if they are asking you most cardiostable IV induction agent, your answer over there will be Etomidate. If they are asking you most cardiostable inhalational agent, in that case your answer would be isoflurane. Okay. Okay. Now, in the respiratory system, what do inhalational agents do? So inhalational agents will reduce the respiratory drive. Okay. Now, the question that they ask over here is, which inhalational agent will cause maximum bronchodilation? So, maximum bronchodilation is caused by halothane. Okay. What about the central nervous system? So, as we know, all anesthetic agents induce unconsciousness, they depress the brain. So all the inhalational agents will reduce the intracranial pressure, they will reduce the cerebral metabolic consumption, and they will reduce the consciousness of the patient. Okay. Now let's have a look at individual agents, and we are also going to discuss the color of their vaporizers. Okay. So if any question, guys, please do write in the chat box. I'm able to see your questions over there, and I will be answering them while teaching you these drugs. Now, halothane. Can anyone tell me what is the color of the vaporizer of halothane? Anyone? What is the color of the vaporizer of halothane? Okay, so the color of halothane vaporizer is nothing but red. Okay, it is red in color. Now, halothane, it is not used very commonly anymore. It was more of an older inhalational agent. Now, with halothane, you have to remember one characteristic feature. It dilates everything. Okay, halothane will dilate everything. It will cause smooth muscle relaxation everywhere. Now, what do you mean by the smooth muscle relaxation or dilatation? So, halothane relaxes the bronchial smooth muscles and causes maximum bronchodilation. Okay. So, what kind of patients will you prefer this in? You will prefer this in asthmatic patients, so that you can cause bronchodilation in them. Okay. Next, halothane will relax the uterus. It will relax the smooth muscle of the uterus and cause uterine dilation. Now, why would you want the uterine smooth muscle to relax and dilate? Suppose your baby is not lying with vertex down, it is lying in the transverse lie, and you want to move the baby so that his head is the presenting part. In that case, you can give your patient some halothane to breathe in. That will cause the uterine smooth muscle to relax. And what you can do is that you can put your hand inside through the vagina and find the presenting part, that is the head or the vertex, and you can move the baby inside as the smooth muscles of the uterus have relaxed and they are allowing this movement. Similarly, you can do it from outside, so that is called as external version of the child. Okay, this is done before delivery of the child. Now, if uterine smooth muscle dilation is being caused by halothane, which condition will you avoid halothane in? So, you will avoid halothane in case of postpartum hemorrhage. Okay, in postpartum hemorrhage, you will have continuous bleeding from the site where the placenta was attached. So you can only stop it after the uterus contracts. So all the uterine arteries will get converged and they will constrict and stop the bleeding. But if you have postpartum hemorrhage going on, you will avoid halothane. So please remember this. Halothane is contraindicated whenever there is postpartum hemorrhage. Now, what are the other cases in which halothane is contraindicated? So the first one that we have is if a patient has any kind of liver condition. Okay, so the patient, when on repeated exposure to halothane, it is seen that there is an immune mediated reaction. Okay, there is an antigen and antibody reaction in the liver and destruction of the normal liver architecture, causing something called as halothane hepatitis. Now this halothane hepatitis is usually seen in obese middle-aged females. Okay, so on repeated exposure, they give history of repeated surgeries and repeated exposure to halothane. You will see they get liver failure, and this liver failure is irreversible, so you should avoid halothane in these patients. Okay, now the next problem with halothane is that it causes arrhythmias. How does it cause arrhythmias? So you have your heart over here, you have certain catecholamine receptors on the heart. So what does halothane do? It sensitizes these receptors. It will sensitize these receptors to action of adrenaline, noradrenaline, and that will provoke arrhythmias in the heart. So as a result of this, we should be avoiding halothane in patients who already have irregular heart rhythm. Okay, so these are the contraindications for halothane: arrhythmias, liver issues, and if the patient has postpartum hemorrhage. Now, the next agent that we have is isoflurane. What is the color of the vaporizer of isoflurane? Isoflurane vaporizer is purple in color. Okay, now with isoflurane, you have to remember that is the preferred agent in 3 scenarios: in cardiac surgeries, in liver surgeries, and in neurosurgeries. Why? Because it maintains good blood flow to all these 3 organs. Okay, so if the patient has any kind of cardiac, liver, or brain issues, neuro issues, in that case, isoflurane is the only agent that will maintain the blood flow to these organs and prevent them from further ischemia. Okay, now what is the contraindication for isoflurane? If there is something called as coronary steal phenomenon. Okay, now what is coronary steal phenomenon? If this is your heart and this is the area which is not receiving blood, this is the ischemic area. Okay, so what should happen over here is there should be dilation of the blood vessels and blood should be provided to this area. Okay, but what happens instead, what does isoflurane do instead, is it steals the blood from this area by causing vasoconstriction over here. So it will cause vasoconstriction in this ischemic area. It will worsen the ischemia in that area and it will steal this blood and give it to some other area. Okay, so this is also called as the reverse Robin Hood phenomenon or coronary steal phenomenon seen with isoflurane. Okay, now the next question that you get is which of these agents is contraindicated in epilepsy? Okay, so remember it is E for epilepsy and E for the agent which causes seizures or epilepsy, and that is enflurane. Next we have desflurane. Color of the vaporizer of desflurane is blue. Okay, now with desflurane you have to remember that it is the fastest to cause anesthesia and the fastest to recover from anesthesia. Okay, quickly goes into the airway, lungs, pulmonary blood vessels, from there into the heart and brain, and quickly when you shut off the agent it comes the reverse way from the brain back into the lungs and outside. Okay, it is the quickest agent to induce anesthesia and to recover from anesthesia. However, what is the backdraw about desflurane is that it is very irritant to the respiratory tract and it can cause spasm of the respiratory tract. Now with sevoflurane, color of the vaporizer is yellow. What do they most commonly ask over here about sevoflurane? Is it is the induction agent of choice. Okay, inhalational induction agent of choice in children because it is very sweet smelling. So the child does not mind smelling it. So how do you induce a child? Is that you hold a mask on his face, you hold the bag and ask him to breathe and blow the bag. Okay, so once he blows the bag like a balloon, You start sevoflurane and you ask him to start inhaling the sevoflurane. As he blows the balloon and takes deep breaths, he will take that sevoflurane inside and he will go off to sleep. Once he goes off to sleep, you can take an IV in the child, supplement the anesthesia with propofol, give muscle relaxant and intubate the child. So this is inhalational induction in a child. What is the drawback about sevoflurane? It forms something which is called as compound A. What is compound A? Compound A is a nephrotoxic compound. So whenever sevoflurane acts with carbon dioxide absorber or soda lime, whenever you are giving very low flows of anesthesia, it can form compound A, which is nephrotoxic in nature. Okay, so it is nephrotoxic in nature. Okay, now the last slide over here is guess the following. They do ask you all these questions in your exam, so I am showing you over here. What is the inhalational agent that causes maximum nephrotoxicity? It causes the maximum chances of renal failure. This is an older agent. It is not used anymore because it causes nephrotoxicity, and it is methoxyflurane, which is the inert inhalational agent. It is an inert gas acting on NMDA receptor, that is xenon. Xenon, it is an excellent agent. It is very quick to act. However, the only drawback about xenon is that it is so expensive that it is not used routinely because of its expense. Okay. Now, which agent produces balanced anesthesia? What do you mean by balanced anesthesia? It produces analgesia or pain relief. It produces anesthesia or unconsciousness, and it produces muscle relaxation. So, which is the agent which produces all three of them? It is nothing but ether. Again, ether is an older agent, not used anymore. And which is the agent which produces phosgene with soda lime? So just like sevoflurane used to react with soda lime to form compound A, there is another agent called trilene which reacts with soda lime to form phosgene. Now this phosgene is also a poisonous gas, and that's why they prefer to ask you about this question. Okay, so we have discussed all the inhalational agent. The last agent that we are discussing is nitrous oxide. Now nitrous oxide is not an anesthetic inhalational agent. It is nothing but a carrier gas. Okay, so it helps in carrying the vapors of your inhalational agent. So it carries the vapors of sevoflurane, isoflurane. Nitrous oxide, however, also has a MAC or a minimum alveolar concentration of its own, and that is 105. Now, next question they ask about about nitrous oxide is what is Entonox. Entonox is a mixture of 50% oxygen gas and 50% nitrous oxide gas. It is used for pain relief in labor analgesia. Okay, so whenever a woman is in labor and she has a lot of pain because of the movement of the child inside, in that case you can hold the mask and give 50% oxygen, 50% nitrous oxide and cause some pain relief. Okay, now important thing about nitrous oxide is it causes something called as diffusion hypoxia and second gas effect. Now let's see what is diffusion hypoxia. Now this nitrous oxide is a very lipid soluble gas. Okay, so towards the end of surgery, when you're switching off the nitrous oxide, all the nitrous oxide from the brain, from all the different tissues of the body will quickly come back into the lungs. Now here your lungs have very less oxygen and suddenly it is filled with nitrous oxide. So there is a condition which is called as dilutional hypoxia. Okay, so it dilutes all the oxygen in the lungs and causes something which is called as dilutional hypoxia or diffusion hypoxia, which is seen specifically with nitrous oxide. So it is recommended that towards the end of surgery you should give 100% oxygen in high flows to the patient so that the lung is filled with oxygen and it does not get diluted by the nitrous oxide. Now nitrous oxide drawback, it increases the pressure in closed cavities. So it is not preferred in neurosurgery where the closed cavity is the cranial cavity. It can diffuse here and increase the intracranial pressure. It is not preferred in tympanoplasties because again closed cavity of middle ear in this surgery. Okay, and the pressure can be increased over here, and it is not preferred in obstruction of the bowel surgeries. Again it is a closed cavity, it can diffuse into that closed cavity and increase the pressure over there. So we are done with all the IV and the inhalational induction agents that are used in anesthesia. If you guys would like to join me on the Unacademy app, we will be discussing all of this in detail, the entire portion of anesthesia that is required for your FMGE May exams in detail. Okay, we have local anesthetics, skeletal muscle relaxants, and opioids, all these drugs to discuss along with other topics that are asked in anesthesia. I would love to see you on the app, and this is my referral code that you can use, Dr. Jhanvi YT. This will help you get 10% off on your Unacademy subscription, and I would love to see you guys there. If you have any doubts about anesthesia, you can contact me on this Telegram group. Thank you for joining me today, and I will see you next time. Make sure you download the app and you're following me on it. Thank you so much, guys.